Good morning, President. Good morning, College. My present name, Innovation Phototherapy for Dry Skin. I am from Uzbekistan, and I work with Republican Specialist Scientific and Practical Medical Center of Dermatology and Venerology of Minister of Health of the Republic of Uzbekistan. Dry skin. Dry skin, a common skin condition in which there is a decrease in the function of the sebaceous and sweat glands, and as a result, a decrease in moisture in both the dermis and epidermis. Dry skin syndrome can be the result of both exogenous factors, domestic and environmental conditions, and the manifestation of endogenous disorders, genetic, hormonal, and immune. Xerosis of the skin, xeroderma, dry skin, is dry skin characterized by dry, raw skin. Sometimes we smell pityriasis like scalp. Skin xerosis is not hereditary and is not associated with systemic diseases. Normal skin has a soft, friable texture dry to its water contents. To protect against water loss, the outer layers of skin contain fat, which slows down evaporation and retains moisture in the deeper layers of the skin. The skin becomes dry when the amount of oil decreases. Which of risk factors for developing xerosis include meteorological exposure, living in a dry, cold climate, elderly age, frequent bathing, especially when using exfoliation soaps, degradation of skin, alkaline detergents, chemicals in production conditions. So dry skin on the hands can become inflamed, leading to hand dermatitis and eczema. Also, dry skin can be congenital with exudations of the skin and occurred secondary, for the example, with a deficiency of the vitamin R in the body, hypofunction of the sebaceous and the sweat glands, as well as with meteorological influences, especially in the cold season, as well as with improved skin and age-related characteristics in this elderly on the physiological state of the body, in which diseases, xerosis of the skin are observed. Dryness. Dryness, xerosis of the skin is one of the current problems in practical dermatology, caused by frequent symptoms of many skin diseases such as atopic dermatitis, ichthyosis vulgaris, sinus itch, psoriasis, lymphoproliferative skin diseases, diabetes mellitus, hyperthyroidism, diseases of the urinary system, chronic renal failure. The clinical picture of dry skin is characterized by the presence of hyperemia, infiltration of the skin on the surface of the which there is a fine plate peeling, accompanied by periods of constant itching. Clinical manifestation. Dry skin is characterized by pathological peeling, the presence of smell cracks, thickening of the skin and its lichenification, decreased turgor and elastic dye to a lack of lipid content. Subjectively, patients may be bothered by mild itching, a feeling of sickness and burning. With long-term itching, if it is accompanied by scratching and rubbing, dry skin can easily become pigmented. Often, dry skin is a prerequisite for the development of various inflammatory skin diseases such as atopic dermatitis, scleroderma, eczema. The classification according to the etiology and pathogenesis of dry skin syndrome can be divided into three main groups. The first group are patients with apparent dry skin. Firstly, these are people with dry skin is caused by the direct influence in harmful environmental factors on the surface layers of the skin. These factors include improved daily skin covering substances containing insults, shower gels, and shampoos. This crop is functional of the sebaceous glands or their adverse effects if climatic conditions. Isolation, where will be raised is the ability of collagen and elastic fibers to bind water. Secondly, it should be not the clinical picture of some malignant disease, lymphoma or granulomatosis, infections, lesions, HIV, viral hepatitis, mental disorders, physiogenetic anorexia, endocrine pathology, diabetes mellitus, and renal failure may be accompanied by acquired dry skin. Dry skin syndrome is also a consequence of side effects from the use of certain pharmaceuticals. For example, externally ablated retinoids, benzoyl peroxidate, acylated acetylate to several grams of treated skin iron, and the use of vitamins, especially nicotinic acid, station and diuretic slate to generate dryness of the skin. In addition, peeling, hyperemia, and thinning of the skin can be a consequence of repeated aggressive cosmetic products, peeling, laser, rejuvenating various types of masks. Second group causes of age-related age changes. The condition of the skin is significantly influenced by physiological changes that occur in the body during certain age periods. During life, there are several periods that are characterized by high dryness of the skin. The first period begins on the second day of the child's life, which is explained by the removal of cases of lubricant and a decrease in skin edema physiological patterns. Increased dryness of the skin can continue during the first 2 to 4 weeks of life and observed in every third child. The second period is for children aged 2 to 8 years because they experience a period of minimal activity of 6 hormones: estrogens, testosterone, progesterone, cortisol, and reduced production of sebum by the sebaceous gland. The third age period is senile age. 75% of people over 70 years old have dry skin, which leads to the formation of microcuts. Dry skin is explained by involuntary dystrophic process occurring in the skin and a decrease in the level of 6 hormones, which are responsible for the stimulation of the sebaceous gland. Third group, constitutional. Dry skin is caused by genetic mutation that leads to structural and functional disorders in the surface layers of the epidermis. These changes in the skin accompany patients from the moment of birth until old age, and the influence of dermal environmental factors and poor lifestyle and aggravate the severity of dry skin. In this aspect, importance is attached to the role filaggrin is main protein involved in the differentiation in epidermal cells and its barrier function. Degradation products are the main components of the skin's natural moisturizing factors. In dermatology practice, dark skin most often occurs with atopic dermatitis being the main symptoms of the disease, which is accompanied with intensive itching. Atopic dermatitis is a hereditary immunotherapy allergic chronic recurrent inflammatory skin disease caused by atopy manifested by intensive itching, symptomatic skin reaction, while dermographism, predominant erythematodes, retinoid rashes in combination with other forms of atopy. According to ICD-10, it represents a group allergic dermatosis including diffuse and localized neurodermatitis, eczema, pemphigus, and other allergic skin diseases which are based in immune mechanisms leading to damage to all parts of the epidermis. Under our supervision, 57 children with atopic dermatitis from 1 First to 18 years old were examined. Girls made it 49%, boys 51%. All children underwent clinic. The diagnosis was established according to the criteria Hanifin-Rashka, severity according to the score index. Molecular genetic PCR studies of the Pilgrim genes, immunological, microbiological, and statistical studies. This slide shows a frequency of distribution of allergic variant and polymorphism of Pilgrim genes and children with atopic dermatitis of the Uzbek population in health control group. Analysis of the distribution of genes Pilgrim predominances of the homozygote genes for the wild allele in the gene Pilgrim. Child population control 100%, and in main group children with atopic dermatitis 75.4%. Heterozygotes variant Pilgrims detected 70.3%. And homozygote variant mutant genotype and 5.3% with child atopic dermatitis. This slide shows expected and observed frequency of distribution of genotype according to the polymorphism genital genes in main group in children with atopic dermatitis. Is follows table is frequency genotype observed genotype normal genotype shows 75.4% and expected genotype 60.46%. Heterozygote variant 90.3% and expected variant genotype 34.5%. And homozygote mutant variants observed shows 5.3% and expected variant genotype variants of near 5%. This slide shows detection rate for Staphylococcus species of the skin in patient atopic dermatitis considered in clinical courses. And in the acute stage in the skin, Staphylococcus species near 70% and high colonization, 78 colonization. And during remission of the skin, Staphylococcus species shows near 40% and colonization 31. And which one factor? Controlled use of external hormonal agents and near 18%, antibacterial drugs near 70%, long-term use of calcineurin inhibitor 49%. Dry skin is favorable environment for the population of opportunistic flora, leading to the development of opportunistic infections that aggravate the cause of dermatitis. Complex forms of allergic dermatitis characterized by opportunistic infection, bacterial, fungal, or viral etiology have become more frequent. The result of culture studies shows that in patients with atopic dermatitis, indicator of Staphylococcus flora inclusion in patients is Staphylococcus aureus near 15%, epidermidis 42%. And clinical characteristics in atopic dermatitis with isolation culture Staphylococcus aureus is methicillin-resistant Staphylococcus and development atopic bacterial syndromes by patients with Invasive allergic form, a bacterial sensibilization in patients with atopic dermatitis. With atopic dermatitis is fungal sensibilization, candidal atopic syndromes. Please. It's candida atopic syndrome, please, with skin. Innovation is the treatment of the dry skin. In dermatology practice, moisturizing creams, emollients are used to treat dry skin, which help increase moisture and soften the skin. However, the use of creams alone does not help to prolong the state of skin moisture and reduce subject sensation itching. As part of effort of innovation grants, new Uzbek parapharmaceutical emollients of the pachyderm line were developed. Silicone contains preparation for external action, moisturizing, toning creams, pachyderm, child's creams, fatty baby. Emollients were prescribed on combination with phototherapy with a wavelength of 633 nanometers. Cream fatty baby is an emollient which contains dexapanthenol, zinc, lanolin, petroleum, usually activates releases water with medicine, mineral, and rare earth elements, hot, soften, moisturizing properties. It is duty is prevent dependence dermate against skin irritation in diaper rash in children. Pachyderm cream in the lanolin salicylic cosmetic cream, domestic produces, which also moisturizing, toning, and regeneration properties for the skin types. As follows from the slide, innovation trip reducing in scored index in patient for 6.1 times compared with indicators from control on the expert moisturizing. Yes. Study of the degrees of colonization of Staphylococcus flora after treatment shows that in the group of patients receiving combination phototherapy, colonization was significantly reduced compared with in the indicators of control individuals. The result obtained very statistical signification. Please shows. And it can be seen from the slide in the main group clinical result was noted in 76 patients. Clinical improvement in 20 to 20.8% and improvement and near 4%. While in control, group, clinical result shows in 26 patients, 40%. During what characteristics comparative characteristics of the clinical course of blood retreat with innovation external therapy during a 1 year of clinical remission of the disease was observed in 87 children out of 101 patients, which was 86.1%, relatives in 30.8% cases. Whereas in the group of patients is control group, clinical remission was observed in 34, which was 52.3%, and relapse of morbidity was observed in 31 cases, respectively. And please, clinical result of therapy before treatment, after treatment in a child with atopic dermatitis. This slide before treatment patient was 28 years old. Can you show my practical use? Combination phototherapy with emollient dermatology and pachyderm after treatment. This combination use of phototherapy with emollients from the pachyderm line increases therapeutic effectiveness and can be recommended in dermatological practice in the treatment of dry skin. Thank you very much. Thank you for your attention. Welcome to Uzbekistan. Invitation to an international conference in Tashkent in 70-80 October this year. Thank you. Thank you.
Dermatome of Bazin, a 4-year-old boy, which is rare in the young children. And I don't have conflict of interest to declare. And here the content that I will cover today. So I'm gonna take this opportunity to mention about the overview about the TB, because according to the WHO report that 10 million people that fell ill of TB every year. Despite this being preventable and curable, 1.5 million people die yearly. And that led tuberculosis is the top infectious killer. And also tuberculosis caused by the bacteria, namely Mycobacterium tuberculosis, mostly affecting the lung and possibly other organs, including the skin. And the prevalence of the extrapulmonary TB, tuberculosis comprise about 1 to 1.5%. And the cutaneous tuberculosis epidemiology was not well reported. However, the prevalence was reported that was high on the country endemic. And the first description of the cutaneous TB documented was Lennick report of his own prostate wart and contract in the post-mortem room in 1926. And the cutaneous tuberculosis caused by the Mycobacterium tuberculosis, Mycobacterium bovis, and under the certain condition, and the bacillus Guerin and attenuated strain of the Mycobacterium bovis. Here is the mechanism action of how the Mycobacterium are transmitted. Firstly, it go from the someone who infected, and then they sneezes, they cough, and to the exposure, and the lungs is the first infection, and then sometimes it heals according to the house immunity. When your immunity is strong, it's 95% heal, and then only 5% turn to latent, and sometimes the reactivation according to house immunity. And only 5% have the local progression and sometimes disseminated to the lungs. We call it miliary TB. And there, how the granulomatous or the cutaneous TB can form by there's 4 main type of the cutaneous TB. And the direct inoculation, it means that the Mycobacterium transmit direct to the skin, and the neutrophil respond, and then the macrophage come to do the phagocytosis, and then the granulomatous formation by as a T helper cell and macrophage and accumulated, and then the granulomatous formation coming up, and also the classification of the cutaneous TB, it could be from the primary inoculation of tuberculosis. It included the tuberculosis chancre, tuberculosis verrucosa, and the endogenous spreading from the primary infection. It could be scropholoderma, tuberculosis cutis orificialis, and hematogenous spreading. It included lupus vulgaris, miliary, and tuberculosis gamma. And here, lastly, the tuberculosis reaction, it included the papillonecrotic tuberculosis, lichen scrophulophorum, and erythema induratum, and the one that we are going to talk about. And here come up to the case. There a 4-year-old boy walking with his parent by the rush on the couch bilaterally for several months. He was a fully tanned boy. Baby with a vaginal delivery received the full vaccination according to the vaccination program of Cambodia. And the rush does not respond with any treatment by the over-the-counter drug. And the patient went to the GP and received the oral antihistamine and oral methylprednisolone topical betamethasone cream for a couple of weeks for the diagnosis of insect bite reaction. And the rush gradually disappeared on the medication. with healing with post-inflammatory hyperpigmentation. However, the rash was reappearing when the medicine discontinued within a week. And our physical examination, we found out on the skin examination, we see the bilateral symmetrical multiple erythematous painful pupule coalescing to nodule distribute on the calf, approximately 10 millimeter for the largest and 3 millimeter with the smallest, with the sparing of the chin. And another full body examination, the other organ is unremarkable. And here is the picture of the patients. And the differential diagnosis were proposed by the erythema induratum Bazin, erythema nodosum, arthropod bioreaction, and cutaneous polyarthritis nodosa, and also lupus panniculitis. And according to this and the previous the differential diagnosis and the previous treatment didn't respond well, so we request to do the incisional biopsy to confirm what exactly is it. And the routine blood check test also request. And the blood results show unremarkable, and the skin histopathology show the lobular and subtet panniculitis associated with vasculitis, and also the lymphocyte and histiocyte and granulomatous formation on this area. So the erythema induratum Bazin were proposed as a diagnosis, as we know that the erythema induratum have a lot of cause, and tuberculosis is one of the cause of it. So we asked the patient about the family history of TB, and the patient denied. And further investigation, like tuberculin skin test, we do not perform because of the patient have received the neonatal BCG vaccination, and we request the chest X-ray, which is the normal result. So we request the interferon gamma releasing assay, like the quantiferon TB gold test, and show the result were positive with the cutoff value 0.35 IU per mil. And the last diagnosis was the erythema induratum of Bazin associated with tuberculin reaction, which is the cutaneous tuberculosis. So the treatment we proposed for the first line was the anti-TB, which is like 2-month isoniazid, rifampicin, pyrazinamide, and ethambutol, and continue another 4 months for rifampicin and the isoniazid. And also the alternative treatment in case like the toxicity of the medication, we adjust the vitamin B6 and the oral antihistamine in condition. And after taking the medicine for 2 months, the rash disappeared, and only the post-inflammatory hyperpigmentation remaining. Here, the dose that we recommend, and in here we usually use a fake dose, not the drug, like the individual dose. And for the monitoring, the regularly physical examination and the skin assessment show no new lesion reappearing. And after the first episode of the anti-TB, the skin lesion subside down and the PIH post-inflammatory hyperpigmentation remaining. And the laboratory monitoring, which is the liver function test, kidney function test, and the kit discussion, and still doesn't show any side effect of the medicine. And sometimes we provide off and on antihistamine in case the patient have the minor reaction like urticaria rash or sometimes. And lastly, the take-home mistake, the cutaneous tuberculosis is rare, but however, it could possibly occur. In erythema induratum Bazin, frequently present on the female adult, but it also occurs in the children. The tuberculin skin test was not recommended for many Asian countries due to neonatal the BCG vaccination. And also the tool diagnosis for cutaneous TB was the tissue culture, the acid-fast basis staining, the PCR, but it takes some time, and sometimes the acid-fast stain doesn't show, and the culture slowly grow, so it gonna like prolong time. And right now, there is a new diagnosis tool, was interferon gamma releasing assay, with the clinical and histopathological and laboratory to confirm. So we decided to treat the patient, and the patient show a very good result. So the proper diagnosis, causal identifications found, and the better outcome of the patient and improve their quality of life. So thank you for your attention.
Gujarat, India. It's my privilege to share with you the findings of an important study titled Childhood Leprosy, a 11-year retrospective study at a tertiary care hospital. Let's start with the introduction about leprosy. Leprosy, also known as Hansen's disease. It is a chronic infectious disease caused by Mycobacterium leprae. It primarily affects skin, peripheral nerves, mucosa of the upper respiratory tract, and eyes. Mode of transmission. Transmission usually occurs through prolonged close contact via droplets of the infected patients through nose and mouth. Now, global and national burden of the about leprosy. Despite the availability of the effective treatment, leprosy's transmission still continues globally as well as nationally. In year 2020, over 127,558 new leprosy cases were detected. Among them, 6.8% were children. In 2020, total 127 countries provided information about the leprosy, in which Brazil, India, and Indonesia continues to have more than 10,000 new cases each. In India, total 6.87% of childhood leprosy cases were detected, which highlights the gap in early detection and contact tracing. Now, why focus on leprosy? Children are more susceptible due to their immature immune system and close household contacts. And childhood leprosy is a sensitive indicator of recent and active community transmission. Importance of it, they are the sentinel indicator of active transmission, plus they provide the insight about the disease progression. And their early case detection is crucial to prevent the long-term disabilities. Now, methodology overview. This was a retrospective study conducted from a year 2012 to 2022 at PDU Government Medical College and Hospital, Rajkot, Gujarat. The children aged less than 14 or younger has been included through passive outpatient reporting. Data were extracted from the hospital register, including demographics, clinical features, contact history, disability, smear positivity, and histopathology were analyzed. Slit skin smear examination and histopathology and routine blood tests were done in all the cases. We have used IAL and Ridley-Joplin criteria for clinical classification and WHO operational classification. And for disability, we have used WHO 1970 disability grading system. What was the study objective? The primary aim of the study is to analyze the clinical and the epidemiological profile of childhood leprosy cases who reported to a tertiary care hospital over an 11-year period. The purpose of the study is to assess the burden and trend of leprosy among children in the Rajkot region, identify the early indicators of transmission, including family, contact history, spectrum of the leprosy, presence of disabilities, or reaction at diagnosis. Data collection. As I say, data was extracted from the hospital records. It was included the demographics, clinical signs, symptoms, contact history, laboratory investigations, and the follow-up. Diagnostic and classification criteria. So diagnosis was primarily clinical, based on the typical skin lesions with loss of sensation and nerve thickening, which was supported by this laboratory investigation, slit skin smear, and histopathology. We have used Indian Association of Leprologists and Ridley-Joplin classification for clinical classification, and for operational WHO classification was also used, that is paucibacillary less than equal to 5 skin lesions or no detectable bacilli on smear, and multibacillary leprosy more than 5 skin lesions and or positive slit skin smear. Disability was graded according to WHO 1970 grading system. Grade 0, no visible impairment. Grade 1, loss of sensation without visible deformity. And grade 2, visible deformities, for example, claw, hand, wrist drop, foot drop. Now start with the study findings. Year-wise distribution of the childhood leprosy. Over 11 years, 47 childhood leprosy cases were documented out of 1,034 cases seen at the hospital. These represent the 4.5% of the total leprosy burden in the center. We can see in the table that the distribution of the leprosy cases trend is fluctuating, but there is no decline. There is no consistent decline in the cases. According to the ANILIPI year 2014-15 annual progress report, total of 1,25,785 new leprosy cases were detected. Among these, 9.04% of the new leprosy cases were children. However, according to the ANILIPI annual report year 2020 to 2021, total of 2,386 new leprosy cases were detected, which makes 5.28% of the childhood leprosy cases. This reduction in the case detection rate is likely due to COVID-19 pandemics and lockdown. Age-wise and gender-wise distribution of childhood leprosy. We have reported the children mostly between 5 to 14 years of age, in which males were higher, 30 cases, than females, which is 17 cases. It makes male to female ratio 1.76:1. The male to female ratio among childhood leprosy cases observed in this study is similar with the findings of many studies conducted over the past few decades. The gender gap is this gender gap is mostly influenced by the cultural and healthcare seeking behavior of the boys. Now, geographic distribution of childhood leprosy. Interestingly, we have found 53% of cases outside of Gujarat, indicating significant migrant influence. That is 31.9% cases from Bihar, followed by 19.1% cases from Madhya Pradesh. And the single case was from Nepal, was an immigrant. High proportion of cases from the migrant population suggest the need for cross-state coordination in surveillance and follow-up. Now, contact history. In this study, contact history has been found in 29.7% of childhood leprosy cases. The risk of infection increases from 35% to 65% if the index case is suffering from multibacillary leprosy as compared to paucibacillary leprosy. Similarly, Gitti et al. Has also reported contact history in 44.1% children in their study. Most of the index cases were parents or close household members, emphasizing the intrafamiliar transmission as a key source. What is the significance of contact tracing? That the study shows the household contacts have a 4 to 9 times higher risk of developing leprosy, which highlights the urgent need for contact screening, early detection, and preventive strategies like chemoprophylaxis or immunoprophylaxis for close contacts. According to the clinical classification, we have observed borderline tuberculoid and tubercular types together formed over and 65% of the cases, indicating a predominance of tuberculoid spectrum. Borderline lepromatous and lepromatous leprosy cases was also seen, which indicates delayed diagnosis and higher transmission rate. Similarly, Mahajan et al. And Kumarwal et al. Has found borderline tuberculoid leprosy 73% and 58.7% in their studies respectively. While data of one place or hospital is variable, but the trend of the form of the disease is still the same. According to the WHO operational classification, we have found 53.2% of paucibacillary cases and 46.8% was multibacillary cases. These findings are similar with the Gitte et al., who have observed paucibacillary cases were more than multibacillary cases. According to the ANILIPI data year 2020 to 2021, it's reversed. Multibacillary cases 11.1% is higher than paucibacillary cases, that is 6.3% in Surat district. Surat is a district in the Gujarat. This data is slightly different from our district because Surat is a high endemic area of Gujarat. Now, according to the skin lesion distribution, nearly 47% of children had more than 5 skin lesions and only 21.3% had a single lesion, which may be difficult to detect early or may mimic other dermatological condition, and no cases of pure neurotic leprosy were reported in this study group. The relevance of the skin lesion is the higher the lesion count suggests the late detection and concerned about the missed early stage diagnosis, especially in resource-limited or migrant population. Nerve involvement. Interestingly, we have found 55.3% of the cases presented with multiple peripheral nerve involvement, and ulnar nerve was the most frequently involved, followed by the common peroneal nerve. Importance of early detection. Early identification nerve involvement is crucial to prevent permanent nerve damage and reduce the long-term functional disability. So for that, we need routine nerve assessment in all pediatric leprosy cases. Delay in diagnosis. In this study, 7 out of 47 children had symptoms for more than 1 year before diagnosis. Similarly, Mahajan et al. Has reported an average delay of 1.5 years for the delay of 1.5 years for reporting to the healthcare facility. And Gitti et al. Has reported a mean duration of 13 to 14 months between the appearance of first symptom and report for checkup at a hospital. Why delays happens? That is due to misdiagnosis, stigma, lack of awareness, lack of training, and limited access to care, especially migrant population. Impact of delay. Disease may progress to multibacillary form, increases the chances of nerve damage and risk of disability, and greater risk of transmission to the close contact. In slit skin smear results, 13 cases were positive, in which 5 cases were borderline lepromatous form and 8 cases were lepromatous leprosy form. Some smear positive children had bacteriological index as high as 5 plus, indicating advanced disease and late detection. High smear positivity in children concerning as it reflects ongoing community transmission, potential for future disability, and it signifies the need for more aggressive detection and early treatment. In histopathological findings, we have found borderline tuberculoid and tuberculoid types were most common, confirming the dominance of tuberculoid spectrum. Lepromatous leprosy and borderline lepromatous forms were also present, some with type 2 lepra reactions, indicating the late stage detection. Minor discrepancies with clinical diagnosis were noted, but it did not affect the treatment protocols. Reactions are less common in children, with only 4.25% in our cases. Disability, we have noted 6.38% grade 2 and 4.25% for grade 1 disability. Well, Mahajan et al. Observed that 13% of childhood leprosy patients in their series reported with disability at the time of presentation, while the situation is not that bad in child cases reporting to our hospital. Methodology overview. In 2020, 8.8% of global cases were global cases in children, reflecting the ongoing community transmission worldwide. WHO reports highlight the persistent childhood infection even in countries with elimination status. In India, 5.28% of cases in 2020-2021 were pediatric. The presence of childhood cases in India suggests undetected reservoir of infection, particularly in endemic and underserved regions. This study has reported 4.5% childhood cases out of all leprosy patients over 11 years, while lower than the national average, but it still reflects the ongoing transmission in the Rajkot region. Diagnosing childhood leprosy is challenging due to subtle clinical presentation, just like often light skin patch or numb skin patch, which resembles the other skin conditions like fungal infection, vitiligo, eczema, pityriasis alba, which ultimately lead to the low index of suspicion, especially among the untrained individuals, and it is worsened by the stigma. Many cases are misdiagnosed. Other dermatological skin condition, as I said, with fungal infection, pityriasis alba, vitiligo, and eczema, which leads to delaying treatment and risking the development of disabilities and chances of nerve damage. So we need greater clinical awareness, careful sensory testing and nerve examination, and referring of the suspicious cases early. Now, that's why slit skin smear and histopathology is important to for accurate diagnosis in uncertain conditions. Now, study limitation. This was a single center study with small sample size and no long-term follow-up was done, and community prevalence was not assessed. Despite the limitation, our study provides valuable long-term clinical and epidemiological profile of childhood leprosy in the Rajkot region. We recommend to strengthen the early detection, expanded contact tracing, improve community awareness and school-based screening, use of prophylaxis treatment, and including inclusion of the migrant population. So, leprosy detection in children make proactive with the school-based and community-based strategies. With the school-based detection strategy, schools are the key because children aged 5 to 14 years are often in close contact environments like classroom, which makes early diagnosis easier. Regular school health checkups will delay in the diagnosis, reduces the community transmission, and reduces the chances of development of disabilities. However, the stigma and lack of awareness hide the symptoms. So to reduce that, we must educate the teachers and school health staff to diagnose the symptoms early, and we should include leprosy education in health awareness program at schools. Community-based intervention is that we must educate family about the early symptoms and importance of the early care. We must train the frontline health workers for basic nerve examination and contact tracing. We should use prophylactic treatment like administration of single-dose rifampicin and MIP vaccine in endemic areas. And we should conduct mobile clinics in high-risk rural and migrant areas which provide on-site screening, diagnosis, and treatment, especially where care is limited. Now we must intensify the NLP efforts by implementing the contact tracing and chemoprophylaxis. We should aim for school-based screening and promote early diagnosis and zero disability target, especially in the children. To conclude, childhood leprosy still persists, delay in diagnosis is still common, and family contact is a major risk factor. Disabilities as presentation still occur. A comprehensive public health approach is needed to achieve zero childhood leprosy. I would like to thank our leprosy counselor, Dr. Tejas Rathod, my Department of Dermatology, Venerology and Leprology, teaching and non-teaching staff, and most importantly, the patients and the families who have participated for these studies. These are the references that guided our work. Thank you for your attention.
Hello, dear colleagues and members of the Third International Conference on Dermatology and Cosmetology. I'm glad to see you. My name is Ekaterina Arkatova, and I'm an assistant professor of the Department of Skin and Venereal Diseases of the Rostov State Medical University and the head of Dermatology Department, Medical Center, Родная Klinika, Rostov-on-Don. The topic of my presentation is experience of successful use of intense pulsed light in the treatment of Shamberg disease. Shamberg disease was first described in 1901 by the renowned Philadelphia-based dermatologist J. Frank Shamberg as a type of progressive pigmented dermatosis caused by extravasation of blood from the capillaries of the skin. Shamberg's disease is the most common type of pigmented purpuric dermatosis, or PPD, and is a benign lymphocytic capillaritis characterized by the presence of petechiae and spots, red-brown or yellow-brown dots several millimeters in diameter, which Shamberg himself compared to ground cayenne pepper grains, most often localized on the skin in the shin area, but also on other parts of the body. Other PPD include purpura annulare telangiectatica of Majorque, pigmented purple lichenoid dermatitis of Gougerat and Blum, golden lichen or lichen aureus, eczematide-like purpura of Duces capitanakis. They are also rare variants of PPD. Data on the epidemiology of PPD are limited. In general, these disorders are considered rare. According to 20 2012, research data on the 100 cases, 79 were men and 21 were women. The ratio was 3.8 to 1. The etiology and pathogenesis are not fully known. Shamberg's disease results from minimal inflammation and hemorrhage in the superficial papillary vessels of the dermis, usually capillaries. The exact cause of capillary inflammation is unknown and may be multifactorial, as there is no association with any coagulation disorders. On the slide, you can see many factors which may play a role in the pathogenesis of this disease. Diagnosis is usually made by clinical examination and identification of the classic morphology of the lesions. Dermatoscopy can be a useful adjunct. Skin biopsy is appropriate when the diagnosis remains uncertain after clinical examination. Patient D, 34 years old, came to an outpatient dermatological appointment at the medical center Rodnaya Klinika, Rostov-on-Don, in 2023 with complaints of a rash on the skin of the shins and thick mild itching. From the medical history, it's known that the appearance of the first rashes has been noted since 2008. Then brown spots first appeared in the area of the back of the feet in an insignificant volume, not causing any subjective sensation. He didn't associate the appearance of the rash with anything, didn't consult a dermatologist, didn't undergo treatment. He noted the progression of the process over the past few years. Multiple rashes appeared on the front and back surfaces of the shins. The rash intensified in the area of the back of the feet. On the slide, you can see dermatoscopy of rash lesions before treatment. The laboratory tests were performed. The results were within normal limits. Taking into account the typical clinical picture, anamnesis data, dermatoscopic data, the final diagnosis was made Shamberg's disease. The patient was prescribed drug therapy according to the Russian Federal Clinical Guidelines for the treatment of vasculitis limited to the skin. After the course of drug therapy, no visible clinical improvement was observed. The patient was still bothered by the aesthetic defect. On this slide, you can see skin process before treatment with intense pulse light in front part of the shin. Or, on next slide, you can see skin process before treatment with intense pulse light in back part of the shin. Taking into account the persistent complaints, the patient was additionally given a single session of intense pulsed light. Each affected area of the skin was exposed to intense pulse light from the M22 laser therapeutic device by Luminis Ltd. The settings of the device are given on this slide. On this slide, you can see skin process 1 month after a single session of exposure to intense pulse light in front part of the shin. Or, on next slide, you can see skin process 1 month after a single session of exposure to intense pulse light in back part of the shin. On this slide, you can see skin process 4 months after a single session of exposure to intense pulse light in front part of the shin or in back part of the shin. 4 months after 1 session of intense pulse light exposure, new rashes were absent. The general erythematous background paled. A stable result was maintained. The patient was offered a repeat session of intense pulse light exposure in the area of unresolved lesions. On the slide, you can see dynamics of the skin process with time. The role of light-based technologies in dermatology and cosmetology has increased dramatically in recent years, and interest in their use is increasing over time. Intense pulse light is used to safely and effectively treat a wide range of skin conditions, including vascular and pigmented lesions, acne and rosacea, and also provides new therapeutic options for other dermatological conditions such as Shamberg's disease. You can find more information on clinical experience of successful use of intense pulsed light in the treatment of Shamberg's patients in Russian Journal of Skin and Venereal Diseases. Thank you very much for your attention.
I am Dr. Nicola Andrada Gabriela. I'm an oral and maxillofacial surgeon, and all my facial aesthetic practice is based on ultrasound. I'm from Romania, the biggest Balkan country, and I want to invite you all to visit these beautiful, unique places in Romania, especially the famous castle of Dracula. So I have nothing to disclose, no personal or financial interest to declare. And nowadays, we are definitely living the aesthetic boom with more than 19 million non-surgical aesthetic procedures performed worldwide. With that, the complications are also rising. So if we make a quick search on PubMed with the keywords filler complication, we get no more than 2,559 results. So the filler complications are divided in mild and severe. The mild ones are the anesthetic results, the chronic edema, nodules or granulomas formation, bone resorption, or even infections. And the severe ones are the vascular occlusion, blindness, and even stroke. All of them with a major impact on the quality of life of the patient. So why ultrasound in aesthetic medicine? Firstly, because it helps us to prevent complication. It is a safer approach. And with ultrasound, we can see what is under the skin. We can also do the vascular mapping, I mean, identify arteries and veins and protect them while we are injecting. Definitely, we can identify with ultrasound what type of filler it was injected onto the face on the patient, because many patients come to our office nowadays and after previous injection, they don't know what material has been injected. So we can identify if it's hyaluronic acid filler, if it's calcium hydroxyapatite, polymethyl methacrylate, silicone oil, and so on. With ultrasound, we can diagnose the complications of the fillers, and even we can guide our procedures of dissolving fillers. Obviously, we love ultrasound because it is a non-invasive procedure. Today on the market, there are many devices of ultrasound. The important thing when we choose an ultrasound device for aesthetics is to have more than 15 megahertz, like a frequency. And here I want to make a clarification. Many practitioners buy an ultrasound and keep it there in the office just in case they have a complication. But in my opinion, things are not like this, because you have to practice every day with ultrasound in order to manage a complication, okay? Because the only problem that has ultrasound is the learning curve. You have to dedicate hours and hours of scanning and make the proper training also. Of course, today we have a lot of literature support about ultrasound in aesthetic medicine. So let's have a look of the mild complication. For example, the anesthetic results. Here is my patient that came to my office unhappy with the aspect of her upper lip, which has a duck look aspect, because the hyaluronic acid filler, it is migrating above the red lip. It is basically on the upper white lip. And we scan the patient. We identify the hyaluronic acid filler deposit that you can see here marked in white. And we dissolve them with hyaluronidase. Here is the aspect of the patient after we injected hyaluronidase under ultrasound. And here is the aspect of the patient after we re-inject the AJ in the correct anatomic plane. Chronic edema is another complication that we can met. Here is my patient that is unhappy with her aspect. She has a previous hyaluronic acid filler injection in the periorbital region, and she fights bilateral malar edema. You can see it here marked in white. And what is the problem here? The hyaluronic acid filler in the periorbital region, if it's not injected on the bone in the supraperiosteal plane, it will attract water and will block the lymphatic drainage. So we scan the patient, we identify the hyaluronic acid filler deposits. You can see here in black, and they are quite superficial. They are not on the bone. They are compressing the lymphatic system, and of course we are dissolving under ultrasound guidance these deposits. This is the aspect of the patient after dissolving with hyaluronidase. I know it looks very bad, so that's why we are re-injecting the AJ under ultrasound guidance on the bone, and this is the final aspect of the patient. Another complication can be of the presence of nodules or granulomas. Granulomas, you can see in this picture, this inflammatory round lesion. It's a granuloma. It's always with inflammation, but the nodules are only accumulation of product without inflammation. Bone resorption, yes, it is possible after filler placement. This is an image of a CT scanning of my patient that asked me what are those holes in my mandible. Well, I asked her if she had a previous chin filler, and she said yes. So we scanned the patient, and here we can see marked in red the AJ filler deposits. Here in green, you can see the mentalis muscle that is pushing strongly and permanently against the hyaluronic acid filler deposit, causing a bone resorption. Infections after filler placement are quite frequent because of the presence of biofilm around the hyaluronic acid filler deposit. This is our patient that came with a recurrent submental abscess that required various incisions and drainages. After that, she presents with a submental chronic cellulitis that won't go away only if we eliminate the cause of the problem, which is the hyaluronic acid filler. So we scan the patient and we identify multiple small AJ deposits. You can see here in black, marked in green. Okay, and we dissolve them under ultrasound guidance. You can see here the needle entering the deposit of hyaluronic acid filler. We inject hyaluronidase and dissolve. This is the complete remission after our treatment. And you can access our article to find out the entire protocol. So let's have a look at the severe complications The vascular occlusion is a phenomenon that occurs after an inoculation of a filler into an artery. Even if it's intravascular injection or it's about compression of an artery, the mechanism or the consequence is the same. Clot formation into the artery that led to a vascular spasm and then to the blockage of the blood flow. So here we have some examples of a vascular occlusion after lip filler. But to understand the physiopathology of the vascular occlusion, we have to understand the concept of the angiosome. What is an angiosome? An angiosome is a skin territory that is irrigated by only one principal artery that sends branches into the skin from deep to superficial. It's like a tree, okay? So these angiosomes are connected, are linked one to each other. And you can see in this image many colorful angiosomes interconnected. This interconnection can be through anastomosis, when two angiosomes are connected by only one small artery, or they can be connected by choke vessels. These choke vessels are very interesting because they act like guardians. In case of lack of blood flow in the tissue, these choke vessels are capable to multiply and replace the lack of blood flow. But in case of a vascular occlusion caused by filler, this choke vessel acts exactly the opposite. They close, they shrink if they detect filler embolus. So let's imagine we have made an accidentally intravascular injection of the filler. So the filler into an artery, of course. The filler embolus will travel into another angiosomes with the blood flow, with the direct, with the positive arterial pressure on the true anastomosis of these angiosomes, okay? And this territory is called accessible arteriovascular territory. Or the filler embolus might travel on this connection, the choke anastomosis. What happens? This choke anastomosis will shrink, will close due to a protective vasoconstrictive reflex. Why? Because they will not let the embolus travel to another angiosome. So, like a consequence, we see an ischemic territory on the skin. There is no oxygen, no blood flow there. So these are the angiosomes of the face with the corresponding angiosomes on the nose and mouth. The vascular occlusion has various stages that we have to know very well to make a good diagnosis. So in the first stage, we can see blanching on the skin, and the patient has a lot of pain. In the second stage, there is a mottled appearance of the skin that can appear in minutes or even hours. Third stage is characterized by an invasion of bacteria with pustula formation. In the fourth stage, there is an early necrosis. And in the fifth stage, the last stage, there is a clear necrosis with a scar formation. So here is an example of vascular occlusion after nasojugal groove filler and piriform fossa. And if we are suspecting a vascular occlusion, the first thing that we have to do is to check the capillary refill. If the capillary refill takes more than 2 seconds, then here is a vascular occlusion. Fortunately, we have the antidote of hyaluronic acid, which is hyaluronidase. So this hyaluronidase is a substance that has a unique property. You don't have to inject it inside the vessel because it can penetrate the wall of the artery or vein. So in 2017, there was published a protocol of injecting hyaluronidase in case of vascular occlusion by De Lorenzi. And this protocol tells us that we have to inject 500 of hyaluronidase every hour in the subcutaneous plane until the remission of the vascular occlusion. So nowadays is the most used protocol, but it's less predictable. It takes more time. Both the doctor and the patient get exhausted. Imagine every hour with the patient in pain, injecting and re-injecting hyaluronidase. And of course, it can fail. Comparing with the 2023 publication of Dr. Schelke, that suppose using ultrasound guided protocol that suppose injecting hyaluronidase under ultrasound guidance. So this protocol is more efficient, is more predictable, and in less than 1 minute, the blood flow is restored. Of course, it requires lower dose of hyaluronidase, but the problem, like I said before, with the ultrasound is the learning curve. So here we have a normal vascularization on ultrasound. You can see this artery irrigating this tissue. Here we have an image of a vascular occlusion. You can see the lack of blood flow in the tissue. And here we have an example of hyaluronidase injected under ultrasound. You can see immediately how blood flow is restored after injecting retrograde hyaluronidase. And if you want to find out more about this ultrasound-guided protocol, you can scan the code and it will guide you to the facial ultrasound platform. So if we have a vascular occlusion and we don't have an ultrasound, the first thing we have to do is to administrate acetylsalicylic acid, 650 milligrams sublingually to the patient. Then we have to inject, like De Lorenzi protocol tell us, 500 units of hyaluronidase per angiosomes every hour, okay? And reevaluate the capillary refill every hour. Of course, we can let the patient go home without treatment. We will administrate vasodilators, acetylsalicylic acid, inflammatory corticoid, antibiotic, and if the patient has the possibility, it will be recommended the hyperbaric oxygen therapy. But the gold standard protocol consists in administrating acetylsalicylic acid to the patient, like I said before, inject hyaluronidase under ultrasound guidance, and restore the blood flow. We can check the patient next day, and if it's everything good, that's it. Very, very briefly, what is the protocol? If we note blanching, pain, and capillary refill more than 2 seconds, we stop the injection, okay? We will evaluate the skin color, the capillary refill once again, and if we have an ultrasound, we detect with the Doppler mode the site of obstruction. We have to treat it very quickly, so we can use the De Laurentiis protocol, that is injecting blindly hyaluronidase every hour, or we can use the ultrasound-guided hyaluronidase injection protocol. We really evaluate the patient every 24 hours and check once again with ultrasound if everything is okay. Here is an example of an ultrasound-guided treatment of a vascular occlusion that it was remitted. And let's finally talk about the disastrous complications that are blindness and stroke. Yes, blindness is a very severe complication after filler placement, and it can happen immediately after injection, or even maybe delayed for up to 2 weeks after injection. And here you have the most risky zones of injection, of course, is the glabella, the frontal zone, the nose, but it can happen also by injecting the nasojugal groove, the lips, and even the chin. And here we have a beautiful image of the irrigation of the retina. The retina is vascularized by the ophthalmic artery. The ophthalmic artery sends collateral branches like the ciliary one, and of course, the most important branches are the facial ones, the supraorbital, supratrochlear, and external nasal artery. These 3 arteries go to the face. So when we inject the face, we can produce, if we inject intravascularly the filler, we can produce blindness by this connection. So, of course, there are connections between veins and arteries from ophthalmic artery to ophthalmic vein. And very important, if the filler embolus, it is located on the principal artery, the ophthalmic artery, in these sites marked in green, then it will produce a sudden blindness. If the embolus is situated laterally, it will produce a deferred blindness. And if the embolus is situated distally, it will produce visual field defects because of the choke vessel spasm. So here are the potential pathways for the filler embolus. Like we said, injection, intravascular injection in the cutaneous branches of the ophthalmic artery that are here, supraorbital, supratrochlear, and external dorsal nasal, are connected with the facial artery. So if we inject glabella, nose, and nasal jugal groove intravascularly, there is a high risk of blindness. Of course, because there are connections between arteries and veins, the same it will happen if we inject a vein in this region. Very important. So whatever it will be the pathway, the consequence is the obstruction of the ophthalmic artery. Protocols in the emergency departments that are created in order to manage this complication, because these complications are coming. So if we have our patient with the suddenly blindness, we only have 90 minutes. We don't have more, because the patient, it will get blind for the rest of his life. It will get irreversible after 90 minutes. So first thing we have to do is to give a patient a bag and ask him to inspire and expire in this bag, because the carbon dioxide is a vasodilator. We have to massage the eyes of the patient to reduce the intraocular pressure and to administrate mannitol. Again, to reduce the intraocular pressure. What can we administrate on the eye of the patient is timolol, brimonidine, acetosalamida, brinzolamide, and of course aspirin. But the more important procedure here in the blindness protocol, it will be the injection of the bulbar hyaluronidase. You have to know this technique, and of course it has her risks. We have to call the ambulance and to send as quickly as possible the patient to the ophthalmologist to make a retina exam. So here you have the emergency kit. If you scan the code, you will get into the last published article of Dr. Nabil Fakih that published this emergency kit, that you have to have it in your office if you are injecting hyaluronic acid filler or whatever type of filler. This is mandatory, okay? And like a take-home message, it's very important the knowledge of the anatomy before injecting a filler into a patient, and please just don't do what other ones are doing. Thank you very much.
This personalized treatment options in dermatology. Why the personalized treatment option is important in dermatology? Because nowadays, means when we learned dermatology, that time we used to treat each and every patient according to the conventional lines of treatment or whatever the treatment protocol that has been given. But when I started seeing more and more patients, then I will notice that there are many genetic variations, many environmental factors are there, which which makes us to go to the personalized way of management of the skin diseases as these. And why this personalization is needed? Because in skin diseases, the presentation is variable. Each and every skin condition is presented in variable manner. Many skin conditions are inherited. So we don't know how it is going to manifest, how it is going to present. And the pharmacogenomics is also different for each and everyone. The environmental factors such as pollution, lifestyle, sun exposure, these are different at place to place. So there is again, according to the condition, we have to personalize the treatment. The patient factors, age, ethnicity, and his Patrick skin type, that is also different from patient to patient. The variable treatment response, that is again important point in dermatology while treating the patients, because if one patient is getting this same result, other patient may not get. So we have to decide according to the patient's overall status. And these are the 4 pillars of personalized dermatology, where we have to go for the pharmacogenomics and omics study, where we can predict whatever the drug response the patient will get, what are the adverse effects that patient will get, and certain rare genetic skin conditions like epidermolysis bullosa, like other palmoplantar keratoderma, psoriasis, acne, alopecia. These all again have different presentations and different prototypes. the microbiome analysis and dysbiosis. That is also again a pillar. Proteomics and metabolomics, that is also one of the major important deciding factors for personalized dermatology. So one of the major pillar is precision in dermatology. We need to be very precise in dermatology. Advanced diagnostic procedures like dermoscopy is always there, but along with that, reflectance confocal microscopy is also there. Assessing skin and architecture by optical coherence tomography. It makes us more precise towards diagnosis. Once the diagnosis is clear, we will be able to manage it more clearly. We can decide the treatment plan for each and everyone, and we can go for the complete line of treatment. Refining diagnosis and defining prognosis by histopathology and molecular testing. Molecular testing is one of the now major emerging testing that helps us in proper diagnosing and giving us the prognosis of the skin condition. According to the genetic variations that are happening, like in melanoma, there are mutations they are happening, and epidermolysis bullosa, there are keratin genetic mutations that are happening. So this is one, and AI can assist. Artificial intelligence can assist in diagnosing through image analysis and help in tailoring the right treatment plans for us. So AI is also again a major important tool which are helping us in diagnosing and planning the treatment for various skin diseases. So what is genomic and omic technologies in dermatology? So pharmacogenomics is like predicting the drug response, what the drug response will get if we decided one set of patient or he is having some kind of genetic variations. How will he get the response? Adverse effects, what adverse effects will he get? Like some we use allopurinol for HS in patient, we get variable response. So we can decide that response. Genetic of skin diseases like psoriasis, atopic dermatitis, rare genetic disorders. We can again identify what are the genetics they are there, and according to them, we can decide the line of management. Microbiome analysis, this is again an important role that plays in diagnosis of movements in atopic dermatitis also, and its management in various other conditions like acne, rosacea, if it is associated with other like atopic dermatitis becomes difficult when it is associated with rosacea to manage. So we have to go for the microbiome analysis, and we have to go for that dysbiosis or cellular changes also. Proteomics and metabolomics. These are the biomarker discoveries that helps us to decide what are the cell proteomics that are disturbed and that can be modified with some other with the newer line of medicines like the biologicals that. And again, digital health is more now affected by artificial intelligence. The teledermatology time-to-time consultations definitely is having a lot of role in personalized management, which provide patient satisfaction. Monitoring skin parameters like hydration, UV exposure by various methods definitely is helping us through the digital and AI platform. For region classification, disease severity scoring, AI tools and technology, these are enhancing our diagnostics, and we are able to manage the patients through this personalized approach. Identifying patients at risk, we are able to modify and these risk factors by identifying these risk factors. Forecasting treatment response, improving predictive analytics. This is helping us in personalized approach. Certain educational apps to create awareness among the patient about the skin conditions to content creation. These are also helping many patients how to get this treatment personalized, because patients, they are also need to get involved in this personalized way of management. So what is their skin condition, how they are going affected, and all this explanation that these apps are providing. The patient-centric approach is a most important part of personalized treatment. So understanding patient's need with the patient involvement and tailored approach to informed consent, taking patient's view into consideration, managing psychodermatological conditions. This is again very important that in psychodermatology, we have to address many of the other conditions, and that need time to time monitoring, time to time managing. Because many times patients feel anxious, they can feel some various queries. And so every time their queries need to get answered, and that actually helps in better compliance towards the disease, towards the treatment plan. So customization of pharmacy according to patient need and history is again important, where we have to decide what conventional line of treatment may not work in each and every one. So we have to customize the pharmacy also according to patients. If the patient is somewhere else, we have to again modify the ingredients, manage that treatment. Targeting holistic well-being of a patient through diet, sleep, and stress management is important toward the compliance of the patient. If we address these issues along with the treatment, they will get the better response. So this is again an important pillar for personalized treatment option. So these are the case studies, few case studies of mine, where acne management, as it needs time to time consultations, and most of the time it creates panic among the patients, as this case studies where the patient is young, 25-year female, and she was just diagnosed with the acne grade 1 again within 3 to 4 days. Because of the stress and other lack of sleep and diet issues, she gets converted into grade 2 acne immediately, and it was causing again a problem in her. So we traditionally we have started clindamycin adapalene, but it was not sufficient. So oral antibiotics is very great. And these are the before and after pictures of that patient with the personalized way. Not only will have to manage it with the traditional line, you'll have to manage it time to time consultations. Again, what are the main concerns, addressing those concerns. There's for that we have to go for hormone profiling, microbiome analysis, personalized skincare solutions, that other of which problem she is having, like glycolic acid, acylic acid, yes, vitamin C serums, sunscreens and moisturizers. These are the most common ingredients. Along with that, we have to add some hyaluronic acid, niacinamide in few cases. So atopic dermatitis is also one of the conditions that again we need a lot of personalization in dermatology. Each and every patient differs according to the presentation, according to age, according to some other comorbid conditions. So every time the similar treatment plan will not work every time. We have to modify the treatment part. Most of the time, even we have to manage the patients with conventional line along with biological JAK2 inhibitors, along with skin boosters, so that the patient can get better benefit. So other conditions where we need this personalization is like psoriasis, where tailoring biologic based on the disease severity, comorbidities, patient profile, and pharmacodynamics is very, very important. Molecular profiling for targeted therapies like newer medicines for BRAF inhibitors that is also again important. And chronic eczema, where we have to along with topical corticosteroids, calcineurin inhibitors, biologicals, and along with that, patient education to avoid triggers to manage the condition. That is also have to be given along with this treatment. So this is the again chronic lymphatic eczema, where we have to study all the patient profile. We have to decide a treatment plan. Then according to the treatment plan, within with 3 months, we are able to get these results. Again, the patient is now happy with this kind of treatment. So if once we have to just maintain the skin condition of the patient. If patient wants complete response, then even we can go further. So what are the challenges and considerations for this personalized care? The cost is one of the major consideration where because there is again physician training is needed, education is required, and advanced therapeutics like biologicals, which are these therapies are costly. Again, other therapies like vet trap and they will need sometimes hospital admissions that again become a cost factor for the patient. Implementation requires healthcare system implementation. So this is good. And the future of personalized care in dermatology is like by combining these different domains or holistic, we have to develop holistic insights, and we have to target the improvement in patient outcomes, which can be achieved with this personalized care. We can develop deeper predictive models through the machine learning and artificial intelligence, which is now progressing a lot and making us more efficient in managing the patients. There is again gene editing and this newer genetic technology that is helping targeted drug delivery in terms of nanodermatology, that is also helping, and that will also help in future. Preventive dermatology is achievable by personalized risk management. So these are the key takeaways. Personalized skincare is no longer a luxury, but a necessity. Integration of technology, genomics, patient-centric care is crucial in personalized treatment management. It promises enhanced efficacy, reduced side effects, and improved patient satisfaction. So we'll have to collaborate with precision dermatology and more towards getting these genetic studies towards this personalized care in dermatology. So thank you for giving me the opportunity to present here. Though life is not perfect, but your skin can be. So we have to keep with that. They have to keep ourselves also in mind in terms of the patient, so that we can give them better results. So this, thank you. Thank you so much.
Is about a miniprotein presenting facial rejuvenative properties, acting as a TGF-β biomimetic. Just who we are. Activen is a Swiss biotech company located in Lausanne. We have a biotech lab in France. So I'm located in France. And our vision is really to offer a miniprotein as a new class of active ingredient, kind of new hero molecule. Although Activen is really a company from aesthetic medicine field, and our mission is to bring this miniprotein. So I have this ribbon, sorry. What are miniprotein? Miniprotein, in fact, are small protein. It's not peptide. The size is below 50 amino acids, and their structure are as protein. They can fold, and by this 3D folding, they can target specific receptor in the skin cells and in the cells, not only in skin. And they are naturally found in all kingdoms. And we have a bioinformatics team which identify in the nature 100,000 mini-proteins, and this is how we developed our new mini-proteins. So just here a schematic representation. Peptides are linear structure, mini-proteins are small proteins, and they can fold. So this structure allowed them to be stable and resistant to enzymatic degradation. They are also small enough to penetrate the skin, which make them more bioavailable. Mini-proteins are growing in the medical application. There is a lot of research on mini-protein for medical application currently. And we have also people who read on the cosmetic field. There is more consumers who are now aware about mini-proteins, more and more. The genesis of this powerful mini-protein, I don't know why we have this, sorry, is because TGF-β is a growth factor, and this growth factor is known to have rejuvenative properties. But TGF-β is a big protein, cannot be used for cosmetic application. This is why we decided to demonstrate and to find in our library if our mini-protein can act as a TGF-β growth factor. And we did different in vitro tests. So here you can see a procollagen-1 assay, elastin and hyaluronic acid. And in this assay, we compared to TGF-β all the experiments. And we can see that for procollagen-1, hyaluronic acid will reach level similar to TGF-β here. And we have an increased dose-dependent effect for elastin molecule. And in this, in the right here, what we did the RNA-seq technology. So we did extraction from human keratinocyte cells, and we analyzed all the genome, and we found a great correlation. So here you can see a great correlation between TGF-β and our mini-protein. Meaning that even though the active, this mini-protein is not a TGF-β, but it acts and stimulates the same genes as TGF-β. This is the rationale of our development. Then we did several clinical evaluations. And these clinical evaluations, we started from doing a first study, which is a preclinical, kind of proof of concept study, demonstrated a reduction of wrinkle, an improvement of firmness, elasticity, and shininess. But then we decided to go deeper and to see if, because this mini-protein is acting on TGF-β, if we can improve dermal epidermal junction, collagen network, but all this data at the clinical level, dermal density and thickness. So I give you here, I don't know how to remove this, sorry. I've tried to remove this. Okay. Up here you can see it better. Thank you. So we use two devices, non-invasive methodology. The confocal. The confocal is a microscope allowing us to measure and to visualize the skin structure at the depth until 200 micrometers. While with the ultrasound, we can have a full thickness of the skin until 2 millimeters. With the ultrasound, we can measure dermal density and dermal thickness, while with the confocal, we were the first to do that. We used this device to quantify the dermal epidermal junction length. This edge papillae, I will explain you what is it exactly, and the collagen fiber, new collagen fiber, which can be visualized, and we measured the perimeter of this collagen fiber deposition. Here, when you have a young skin, you have this kind of wavy dermal epidermal junction. This is a structural representation. While with the aging, this dermal epidermal junction become flat. And when we measure the dermal epidermal junction length in the same area, if this dermal epidermal junction length increase, this means that we have a kind of rejuvenation, because if this dermal junction is flat, we have a shortening of the dermal epidermal junction. This is what we measured with this device. And when we discuss also about the edge papillae density, with the confocal, we have a kind of optical cut of the skin. So we have a horizontal cut of the skin. So when you cut the skin, I show you with my hand like that, this dermal papilla appear, we see this type of a rounded shape, horizontal optical cut of the skin, and this rounded shape are called edge papillae density. We measure these different rounded shape, and this rounded shape give us the value, the ID of the wavy of dermal epidermal junction, the wavy form. If we have a less a rounded shape and a less round shape in the same area observed, this means that we have a flat dermal epidermal junction. This is what we measured, and here is just to show you the typical pictures of confocal. This is here a typical structure of histological skin section, while here it's a confocal picture obtained by microscopy. What we found before and after, just after 2 months, this is the miniprotein. So, sorry, we asked people to apply twice a day the product on their face, half face with a placebo, which is the formula without the active, which is the miniprotein at 2.5%. The study was done on 26 women, aged between 40 to 60 years old, and these ladies present saggy skin and dual complexion. After 2 months, we have a significant difference between the vehicle, placebo control, and also we have a significant increase of edge papillae, which means that we have a rejuvenation of dermal epidermal junction. Also, we measured this length, and also after 1 and 2 months, we have an increase, a steady increase of dermal epidermal junction, and this effect after 2 months is significant in comparison to vehicle. We measured also, as I explained, with the confocal, we can see the collagen fiber. Here you can see in the here with my mouse here in white, we measured this new collagen deposition, and this new collagen deposition we can measure exactly the collagen fiber perimeter. And what we can see in the miniprotein group, we have a steady increase of collagen fiber perimeter, which means that we have a new deposit of this collagen protein just below the dermal epidermal junction, because we can see here the edge papillae also. And while with the vehicle control group in the placebo, we have no improvement, which is expected during all the course of the study. We measured the dermal thickness with the ultrasound. You can see in the scale here, you see we are in millimeter. I explained that with the ultrasound, we can measure the thickness of the skin around 2 millimeters. So we can see here before and after 1 month increase of dermal thickness of the skin. And here we have also, because the study was placebo controlled, we have also an improvement in comparison to a placebo. Against, in the placebo control, we have no improvement after 1 month, which is expected. The placebo do not improve the skin properties. Here you have a 3D reconstruction of ultrasound pictures, and we can see, for example, before the start of the study, you have a lot of white space, which means loss of extracellular matrix. After 1 month, we have less white space, and the skin is clearly densified, which mean that we have a new production of extracellular matrix. I showed you, thanks to ultrasound, with a confocal, that we have an improvement of collagen below this area, but with the ultrasound, we can have a deeper view, and we have a densification, not only close to the dermal epidermal junction, but also through all the dermis. Just some pictures on this woman, showing that we have an improvement of wrinkles area, and also we used this device, which is the Visia, and with the Visia we can estimate the age of our panelists through image analysis. And interestingly, after 2 months, we have, and in green, it's really the miniprotein group. We can see a reduction of esteemed age, so they appear younger, while with the vehicle control group, we have in fact a tendency to appear older, or we can say no clear improvement. But we here discriminate clearly between the vehicle control and the active ingredient group, where we have a rejuvenation of this active ingredient. Lastly, this is just to show you some pictures. In this lady, which is older, we have a kind of a reverse aging process, while here this lady is younger. We have kind of slowdown of aging process because we have less wrinkles appearing. Just a reminder here, this data, we showed also that we increase skin elasticity with cutometry, skin firmness also after only 2 weeks, and after 1 month we have still this effect. So firmness and elasticity were improved, and in our study we found that 96% of the women showed an increase in their dermal density. So almost all people have a benefit when they use this miniprotein. But based on a marketing point of view, we did a study, and what is the first claim looking by the consumer is for sure fine line and wrinkle, but the second one is loss of firmness and skin sagging. And because we have demonstrated that this miniprotein is able to improve the firmness elasticity, we were asking maybe this miniprotein can also improve and limit facial sagging. So what we did a new clinical study enrolling 33 women between 49 to 70 years old. We did a strict selection of women only having a facial sagging from grade 3 to 5 to be sure that yes, they present facial sagging. And because most of our competitors do not, when they study anti-sagging effect of cosmetic active ingredient, they just show visuals, but they do not do quantification. So we were asking, how can we demonstrate that this miniprotein can improve facial sagging by quantification? So what we did image analysis. You can see here in yellow, and we can, thanks to this line here in yellow and here in yellow, we can precisely follow during the study this area. And if this area is improved, is reduced after the use of the miniprotein, we can demonstrate that we have a reduction of facial sagging. Although usually people, when they study sagging, they don't use only one group and an hemiphase study. They do 2 groups because it's easier. And in our side and in our company, we decided to study this effect, also in comparison to the vehicle, so the formula without the miniprotein. And the study was done in the same panelist, the same volunteer apply either in the left or right of their face the miniprotein formula or the vehicle. And because we would like to be sure that when we use some grading, our measurements are relevant. What we did here, it's our internal data. The age of panelists are in x-axis, and here in y-axis we have a score of this deficiency. What we can see, this score is really correlated with the age. So when we use, for example, people from 40 to 72 years, we have really a correlation between sagging and this grading. So this grading was done in the lab where we did the clinical study. So our technician do the good grading. So this is expected. This validates the first step of the study. Also, what we did, because we would like to see, yes, maybe this area is just a value, but it's not correlated with a clinical grading. So if this area is correlated with clinical grading, so we can be sure that if we have an improvement, this is relevant. This is what we do. We did a correlation between clinical score and this facial sagging area, and this is our data. We measured it on 58 people, and we can see here a correlation between score age and facial sagging. Also, I forgot to mention it, sorry, because sometimes in clinical studies, the woman starts a diet. We would like to be sure that if we have an improvement, this is not due to loss of weight. So we measured the body mass index during the study. And interestingly, we found that during our study, the body mass index was not modified. So if we have an improvement, this is not due to body mass index evolution. I show you some results here, which is this area of parameter. I mentioned that if this yellow area is decreased, so we should be below 0. So we have a reduction by -2 square millimeters. And this measurement is clearly seen here in the miniprotein group. While with the vehicle, we have no improvement. It's in gray, the vehicle is in gray. And after 1 month and 2 months, we have a difference between the hemiface in a receiving vehicle or the hemiface receiving the miniprotein. And this is, and after 1 month, we achieved the maximum of result. So we have a clear improvement of this facial sagging. Again, when we ask our panelists, do they see a difference between the left and right area of the face, sorry, so 70% of ladies ask that yes, they found their facial contour improving, which is quite high because it's difficult to see a difference between left and right on our own face. What we did also, because I focused until now only on this area in yellow, but when we did the 3D picture, we noticed that the improvement was not only in this area, but also on all the lower face. So from below the nose until the chin. And what we did by image analysis, again, we put a mask in gray for the baseline and in a white mask after 2 months. And when we do the superposition of white and gray mask, if there is an improvement, the white mask cannot recover the gray area, which is the case in the hemiface treated by miniprotein. So we notice that when we see all this gray area, when we do the superposition, this means that we have an improvement of facial sagging along all this basal lower face. And here, just to show you some pictures of this lady. At the baseline, this lady got a really square face shape. After 2 months, you see it's very smooth, and we improve this oval face. Just to show you it here, some visuals. And here is just a kind of movie, and before and after. You can see it's very square, and how now it's a rounded shape. So to conclude, we have demonstrated from in vitro 2 clinical studies that this miniprotein is a powerful skin rejuvenation active ingredient, acting like TGF-β. And we have shown its action on dermal epidermal junction. They stimulate collagen demonstrated in vivo at the clinical level. We have a densification of dermis, a thickening of dermis, and also a novel face restoration. Sorry, there is a mistake here. The ends is missing. And also as a reminder, this miniprotein won a lot of innovation award since 2022, because we did a lot of studies on that. And we published this data in a peer-reviewed journal. And recently, I presented this data also in a dermatological congress in United States to demonstrate this oval face improvement. So thank you for your attention. I hope I was not too fast. And if you have any question, feel free to ask me. Thank you.
Thank you, Doctor. That was an excellent.
Pemphigus vulgaris is an autoimmune disorder. So what's so special about this is, I'll be talking in the first few slides why we wanted to present this particular case. Yeah, next slide, please. Yeah, next slide, please. So Pemphigus vulgaris is an autoimmune blistering disorder, which is mainly characterized by the autoantibodies against desmoglids. And clinically, it is mainly characterized by painful blisters and erosions on both skin as well as the mucosa. Now, we know that it's mainly an autoimmune disorder, and this autoimmunity is mainly triggered by multiple causes, one of which is the most important viruses like herpes simplex and herpes zoster. But recently, it has also been seen that coronavirus 2 is also known to induce the autoimmune process and thus cause pemphigus in genetically susceptible individuals. Now, why this particular case report? Now, we all know that many cases of Pemphigus vulgaris have been reported after COVID-19 vaccination in particular, but there are very few cases of Pemphigus vulgaris after COVID infection per se. So we report this case of Pemphigus vulgaris, which was developing in a patient around 35 days after the onset of symptoms of COVID-19 infection, but not vaccination. Yeah, next. Yeah. So a 45-year-old male patient came to our OPD with a painful oral erosions of 2 months duration and skin erosions of about 1 month duration. Now, on examinations or the history what he gave was the oral erosions initially started over the buccal mucosa and then gradually spread to involve the entire palate, gingival, labial mucosa, which resulted in extreme difficulty in eating, swallowing, and even to such an extent that it was difficult for him to even speak properly. He also gave the history of fluid-filled blisters initially started over the abdomen, which ruptured to form non-healing erosions. Then gradually they spread to involve the entire body, involving almost around 70% of body surface area. Now, the important point on asking for the history, he gave there's a history of fever with sore throat around 1 month before the development of oral erosions, which was diagnosed to be COVID infection by RT-PCR. However, the COVID infection was mild and the patient was treated at home with supportive treatment and the antipyretics. Now, this is a picture when he first came to our OPD. He presented with multiple erosions with erythematous base and few crusted lesions which were present over the back. Now, cutaneous examination, he had very few intact blisters because most of the blisters were almost ruptured leading to the formation of multiple erosions as we saw in the first picture, with overlying crusting covering the entire back and even on the abdomen, thighs and arms. Nikolsky and Perenikolsky sign were positive, indicating that the lesions and the disease was still active. Oral examination also showed similar erosions covering the entire buccal mucosa. His vitals were stable and the baseline blood investigations were normal. To confirm the diagnosis, we have taken a biopsy from an intact blister and this skin sent for the histopathology. This showed the picture 1A shows the characteristically suprabasal split with the intraepidermal vesicle formation. However, the second picture 2B, which is circle component, shows the multiple number of eosinophils and very few acantholytic cells. The presence of these acantholytic cells and the suprabasal split within the intraepidermal vesicle confirm the formation or confirm the diagnosis of Pemphigus vulgaris. However, direct immunofluorescence or DIF was not done in this patient as the patient was not affordable for the DIF procedure. So the diagnosis of Pemphigus vulgaris, patient was initially suggested for rituximab. However, patient could not afford rituximab and so patient was started on what is called as DCP therapy, dexamethasone cyclophosphamide pulse therapy. That is, dexamethasone 100 milligrams is given in 5% dextrose intravenously over 3 hours on 3 consecutive days. And on second day, cyclophosphamide 500 milligrams is added to that. Now, after the 3 days of DCP therapy, the patient is then continued on oral prednisolone 40 milligrams and oral cyclophosphamide 50 milligrams. So within 2 weeks of starting the therapy, the lesions started healing and crusting almost around 80% of the lesions. So the patient came back for review after 1 month. However, he refused the DCP therapy again because his lesions have almost healed completely. So in spite of repeated counseling, patient refused the DCP therapy and thus the patient was maintained only on oral prednisolone and cyclophosphamide. Now these two drugs were slowly tapered and stopped over a period of 7 months. And 7 months he had no exacerbation of the lesions. And after 7 months, since there were no lesions, we lost the follow-up of the patient. Now this is a picture 2 weeks post-treatment. It shows completely healed lesions with post-inflammatory hyperpigmentation. And you can see very small, tiny erosions here and there over the back. These lesions have also completely healed with the oral prednisolone cyclophosphamide at the end of by around 2nd month. So coming to the discussion part, as we all know, SARS virus or the COVID-2 virus has various cutaneous manifestations in the form of urticarial lesions, chilblain-like lesions, vesicular eruptions, maculopapular rash, and even livedo-reticularis pack. Post-COVID infection, many autoimmune reactions have been noticed, of which the most important were the Guillain-Barré syndrome and the Kawasaki disease. However, along with these common systemic conditions, many cutaneous autoimmune phenomena also have been studied in relation to the COVID virus. Now, it has been seen that of the different types of autoimmunity, IgG-mediated autoimmunity has an important role in the pathogenesis of autoimmune disorders. Now, how COVID-2 is leading to these autoimmune skin disorders? So, the important point is the human proteome and the viral elements of the COVID virus are known to have some structural homology, because of which this led to the cross-reactivity and thus production of the autoantibodies in the normal cutaneous persons. Now, in particular, again, the COVID virus again has higher potential to trigger autoimmune disorders because of two important factors. First thing is, it is known to cause hyperstimulation of immune system, which in turn leads to excessive production of pro-inflammatory cytokines. Now, these cytokines are known to induce the autoimmune process and thus lead to the autoimmune skin disorder, especially the Pemphigus vulgaris, bullous pemphigoid, and even Pemphigus foliaceus. Now, for the first time in 2021, Medeiros et al., he suggested or he reported a case of Pemphigus vulgaris as an autoimmune phenomena developing after COVID-19 infection. However, since then, only very few cases of Pemphigus vulgaris have been reported following COVID infection. Now, as we have discussed so far, like any other virus, coronavirus also can trigger the autoimmune process by 3 main mechanisms. Now, the 3 important mechanisms which can be the reason for COVID virus triggering the autoimmune mechanism are, first thing is molecular mimicry. This we have already discussed just now. There is structural similarity between the viral antigen and the host antigen, leading to the autoantigen identification. And the second important process is called as bystander activation. That is, whenever there is a cytolysis process due to the virus, that leads to the exposure of self-antigens, and these self-antigens are again act as a normal autoantigens, leading to the stimulation of the immune system and autoantibody formation. The third process is an extension of the bystander activation, that is epitope spreading. Now, whenever these self-antigens are exposed, sometimes there is a release of these antigens due to the virus, which in turn leads to the exposure of the endogenous epitopes, and that leads to the development of the so-called autoimmune process. Now, coming to the duration, when this usually vulgaris or the autoimmune process start after the COVID infection. Pastukova et al. Suggested Pemphigus vulgaris 2 weeks after testing positive for COVID-19 infection. So this short duration between the infection and the autoimmune condition says that the viruses can initiate the autoimmune process immediately, leading to the autoimmune disorders like Pemphigus vulgaris. However, in our case, the lesions of Pemphigus were noticed 35 days after the onset of COVID infection. Now, this delay also can be explained that there is a strong permanent autoimmunity will develop after the initial inflammatory response by the coronavirus. The Medeiros et al., who actually reported the Pemphigus vulgaris for the first time, also reported the lesions about 40 days after the coronavirus infection. Now, not just so far we've been talking about the Pemphigus vulgaris following COVID virus, but there are also case reports which show the development of Pemphigus lesions after the COVID vaccination as such. Now, how this happens, let's have a brief look. The mRNA of the vaccine is known to upregulate the production of the interleukins, mainly interleukin 4, 17, 21, and tumor necrosis factor. These interleukins, as mentioned earlier, will stimulate the autoimmune process and can thus result in the Pemphigus vulgaris. So finally, to conclude, coronavirus can trigger the autoimmune response by either one of the three mechanisms, that is by molecular mimicry, bystander activation, or epitope spreading. So we report one such case of Pemphigus vulgaris developing after the COVID infection and thus adding to the early basket of such reports. So these are the references. Next slide, please. Yeah, next slide. Yeah, so thank you so much for the patience hearing. I would like to take up any questions, if any.
Clive and Struve for giving me a chance to participate in this conference, and they are helping me in my patients. Next. Today, nowadays, we have a disease called mastocytosis. It's a rare and neoplastic disorder characterized by proliferation and focal accumulation of clonal mast cells in various organ systems, including the skin and the bone marrow and other internal organs. Although the number of diagnosed cases of cutaneous and systemic mastocytosis is increased nowadays, mastocytosis is still considered a rare disease with a complex pathogenesis and unpredictable clinical course. Next. In Moscow, we have predicted the first time cases of cutaneous mastocytosis among the pediatric population of Moscow for period from 2019 to 2022 in absolute number. As you saw in the graphics, number of mastocytosis cases, annual growth and decline rates from 2019 till 2022, it's rising for 4.8 times. So to give us attention to see what about this disease from the rare disease to abundant orphan disease nowadays. Next. As you saw it from also dynamics of incidence rates of cutaneous mastocytosis among the pediatric population of Moscow from 2019 till 2022 per 100,000 population aged from 0 till 17 years. From 2019 till 2022, as you saw it from incidence rates, 16.6 times from 2019. Next. For World Human Organization classifications, as you know, 2022 skin mastocytosis is giving 3 differentiated types like maculopapular cutaneous mastocytosis, monomorphic type, polymorphic type, and the skin mastocytoma. Today we are going to be detailed more about diffuse cutaneous mastocytosis and about systemic mastocytosis and localized mast cell tumors. Next. Definitions about DCM is a rare and the most severe clinical form of cutaneous mastocytosis in children. Extensive spontaneous blister formation is a predominant clinical features of the disease during the neonatal and infantile periods. Rubbing or scratching skin lesions in DCM causes immediate release of mast cell mediators, leading to flushing reaction, urticaria, up to development of anaphylactic shock. And they take care about this potentially fatal outcomes. Next. Epidemiology of DCM in Russian. In Russian, DCM is a rare and the most severe clinical manifestation of mastocytosis in children, but researchers estimates regarding the prevalence or incidence rates of DCM vary significantly, ranging from 1 to 5% till 5 to 13% of all pediatric mastocytosis cases. According to Potapenko scientific authors and others from 2021, prevalent or incidence rate of DCM in St. Petersburg, it's about city in Russian, was reported to be less than 100% among all pediatric mastocytosis cases. In Moscow, prevalence of DCM has been documented at 1.6% in all of cases. Next. Dynamics of clinical picture of DCM. As you saw it at birth or on the 3rd day of the life, it's beginning with focal erythema and redness, flushing at all of the body, itching in the body, pruritus also, urticaria, and also not only in this part and also in the head and the back of the and the buttocks of the children. On the 3rd day of life, as you saw it, it begins to make like papules, make it to begin like urticaria, more like edema and others. Next. As you saw it also before treatment, as I told at the back, how it's look like at the head of the back of the head and neck and all of the body, it's very itching and can't give the shoulders to sleep kindly. So it's a very harmful disease. Next. Clinical manifestations also of DCM before treatment, as you saw it can come in all of the body, anywhere. Can be also at the growing parts, between maybe it comes at the upper of the genital parts. Also, as you saw it in the head of the patients, maybe at the focal parts. All these are kindly giving distribution of diffuse cutaneous mastocytosis all over the body. Next. Dermoscopic also pattern of DCM before treatment, as you saw it begins with 1 dot and it will begin to give spreading with widely from 0 till 10 millimeters. You understand? So if we didn't treat it, it can be more widely at the all of the body and give more focally and erythema at the parts of which begins. Next. Morphological also examination of skin biopsy. You have to take care about 2 things. First thing, from the A parts, dense lymphomonocytic infiltration in dermis by hematoxylin stain and magnification by 100. And second one, from B, detachment of epidermis formation of subepidermal blister, hematoxylin magnification 100, as you saw it in pictures. Next. A positive reaction was observed in majority of infiltration cells. Immunohistochemistry performed using anti-CD117 antibodies, magnification by 100. Next. What are the clinical dangers of bolus for variants of diffuse cutaneous mastocytosis? Accompanying symptoms that aid in differential diagnosis of diffuse cutaneous mastocytosis, including bleeding, urticaria, urticarial dermographism, gastrointestinal manifestations such as bleeding, vomiting, and diarrhea. Life-threatening complications may include vasodilation, hyperemia, anaphylactic shock, abdominal pain, gastrointestinal bleeding, and fatal outcomes. So we have to take care about these symptoms to give like alarm for this disease. Clinical and laboratory parameters reflecting the severity process in patients with DCM at the initial examinations. As you saw it in the graphics, I know it's written in Russian, but I am going to translate it. We have 4 parts. For score, as you see it from all patients were normal, but when we found it, their tryptase, it's more than 8 milligram per liter. So it's increased more times, and for chemotactics, monocytic chemotactics parts 1, it's increased more times and double times. So for this, it gives us alarm for diffuse cutaneous mastocytosis. Next. You saw from graphics correlation between serum tryptase levels and MCP-1 over CCL2 chemokines concentration in patients with diffuse cutaneous mastocytosis. You saw its correlation is begin to rise and will be correlated between tryptase levels, high tryptase levels with high MCP-1 CCL2. Next. Also, as I told before, diffuse cutaneous mastocytosis in a patient, 2-year-old patients, how you saw it's look like from the beginning with small papule dots and begin to spread to 10 millimeters or more. It depends on the side of the buds. Next. Also, we can see in severity of fibrosis in focal lesions of DCM. You see this fibrosed focally also and increased widely with erythema. Next. Dynamics of disease course for the patients from 3.5 years. As you saw, it's very clearly on the head of the parts and all of the body, it's treated from this disease. Next. Also the same things, this diameter begins to diminish and it became clear of all of the body from these papules and the focals and the clonal parts. Next. Recommendation for avoiding triggers. How to avoid these triggers? By sudden temperature changes, extreme temperatures during showering or bathing, dry skin, use of moisturizers, rubbing, friction, intense physical exertions, medications like NSAIDs and others. So all this is important for avoiding triggers for these parts. Next. Conclusions. All observed children with DCM had serum tryptase levels exceed 11 milligram per millimeter. A tryptase levels above 8 is considered an indicator of high risk for anaphylaxis. All children with DCM experience episodes of anaphylaxis requiring hospitalization because of these symptoms which we told about it, like gastrointestinal manifestations, like bleeding, like wheezing, urticaria, and many others which can potentially give fatal outcomes. Although disease is rare now, but due to increasing number of children with cutaneous mastocytosis, doctors should be worried or suspicious of children with high tryptase levels and make more consultation and analysis for these patients to give a good treatment for them and not to give potentially for them fatal outcomes for it. Next. Thank you for your attention. I would like you to give you this information and put in your mind this disease nowadays are more abundantly in our world, so we have to take care to give the right diagnosis and with the right treatment. Thank you for attention. I would like that you got a good information from me.
Thank you so much, Doctor. If anyone has any questions to ask, please turn on your mic and directly ask, or you can drop it in the chat box.
Is just essentially run through a recent meta-analysis article that we've done regarding dermal filler injections. Essentially, it's a research paper regarding the risk factor analysis for vascular occlusions in dermal fillers. So just an introduction to dermal fillers. So as you may all know, dermal fillers are types of fillers which are used to restore volume in the face. They can be used to enhance contours and also reduce wrinkles. Now, in the UK and especially worldwide, the sort of there is a huge increase in popularity in sort of aesthetic procedures, with dermal fillers being one of the most popular one. In the last couple of years, it has increased quite dramatically. And so the common materials that we could use in dermal fillers generally are hyaluronic acid, being around 60 to 70% of the fillers used now. In the past, there have been different types of fillers, such as calcium hydroxylapatite and polyl-lactic acid. Now, generally, fillers are very, very safe. However, there has been some rare complications, and the most worrying complication is a vascular occlusion. And the prevalence of that, or the incidence of that, essentially is between 0.01 to 0.05% worldwide. Now, just a bit of information and background regarding what vascular occlusions are. So vascular occlusions are when the filler particles enter the blood vessels, and usually we're talking about arteries rather than veins, or they also can cause extrinsic compression, so they can compress the vessel. And as you could imagine, if we block an artery or compress an artery, that can cause ischemia, and then that could also cause necrosis. Now, depending which vessels are being blocked, that could cause different outcomes. So if you're blocking, for example, the retinal arteries, that could cause vision loss. If you're blocking, say, some of the labial arteries, that could cause more soft tissue loss and scarring. So these are quite important complications that we need to discuss. And in general, in the aesthetics industry, there hasn't been much evidence-based medicine regarding this. And a lot of our protocols come from case reports or best practice. Now, urgent recognition and treatment is definitely critical for these conditions, because based on that, that could impact you having a full recovery or having permanent deficit from that perspective. Now, a bit onto the objectives of our study. So it was a systematic literature review and meta-analysis. And what we wanted to do was identify the patient and procedural risk factors for vascular occlusions. So we were trying to see whether there were any patient risk factors that could also increase the likelihood of somebody getting a vascular occlusion rather than somebody else. And what we really wanted to do was to inform clinical decision making and enhance safety, and see whether there was anything that we could come up to help reduce the risk of vascular occlusions in the future. Now, a bit on the methodology. So we did a comprehensive review, and it was mainly conducted in PubMed, Embase, and the Cochrane Library. And after going through our inclusion and exclusion criteria, we managed to find 14 studies, which varied between case series, cohort, or case control studies in total. And we extracted various data from that. So the main data was the demographics of the patients, if it was mentioned, the filler type, so whether it was hyaluronic acid, calcium hydroxylapatite, or something else, the site of the injection, the vessel that was affected in terms of vascular occlusion, and also the final outcome from the patients. And we assessed the risk using the Joanna Briggs Institute checklist. Now, this is just an image of what we have found. So I'm just going to move this slightly out of the way. So this is the identification stage. So we found in total around 100 and, so in total from various different, from PubMed, Google Scholar, Cochrane, various different articles. And the total number was around 109, with 112 removed. Now, based on our exclusion and inclusion criteria, we excluded another 64, and essentially went all the way down to having a total of 14 studies included in this review. Now, some of the main reviews of or the key findings of this article. Well, number one, 71% of the cases occurred in females. Now, we don't feel that this is due to females having an innately higher risk profile than males, but rather than females are more likely to conduct these fillers, and it was probably just to skew that more females in general conduct dermal filler procedures compared to males, and that's the reason there is quite a large skew in terms of a lot more females had vascular occlusions rather than males. Now, the mean age was around 42. Again, fits in with the idea that dermal filler procedures are generally done in middle to younger age people compared to the elderly. and hyaluronic acid was the most commonly implicated filler. And again, that fits in with the idea that now, in this day and age, the most common filler we use is hyaluronic acid rather than the older fillers such as the calcium hydroxylapatite, which, although is coming more into use nowadays, is still less common than the hyaluronic acid. Now, unfortunately, there wasn't much demographic data in the various case reports or case studies in terms of various past medical history or any other interesting data that we could take out to see if there were any other links which increased the risk of vascular occlusions in terms of patient demographic. Now, risk factors essentially came in as the high risk areas. So in terms of high risk areas, what we call is the areas which have increased vasculature or also have or are tributaries of different arteries. So for example, in the glabellar region or the nose region or the nasolabial folds, for example, you have the angular artery, which is a subsidiary eventually or goes down to the retinal arteries. And so these high risk areas have increased risk of having more profound impacts just because of the vasculature and the nature of some of the end organs that they supply. So high risk areas were the glabella, the nose, and the nasolabial folds, and occlusions in minor arteries had better prognoses. So if it was a small artery, then we were able to find that the outcomes were better, whereas if it was a large artery occlusion, then the outcomes will be less favorable. And of course, if there was a delayed intervention, so greater than 5 days in our findings, it led to permanent deficits. And again, that just alludes to the fact that if we leave things longer, then you will get irreversible necrosis and tissue damage just due to the time that there has been no blood supplied to that specific area. Now, the management used, and generally in the aesthetics industry, the management is generally standardized. So for all hyaluronic acid related complications, we use hyaluronidase, and that is the first line treatment that we tend to use. In other fillers such as calcium hydroxylapatite, there is no real reversing agent. However, the data suggests that we can still use hyalase or hyaluronidase or saline to try and flush the area. Now, 84.2% of the patients in our study showed partial or full recovery. And this was the first line treatment. And essentially what the treatment is, so hyaluronidase is an agent which dissolves hyaluronic acid. The idea is that if you have a blockage in one of the arteries, you use hyaluronidase to dissolve the hyaluronic acid in the artery, and that allows us to restore blood flow into that area. And that's the mainstay of treatment. There are other things that we can use, such as aspirin, GTN to dilate the vessels, massage as well to help also dilate the vessels, and heat compress, which again causes vasodilation. Now, we managed to develop a risk stratification tool in our systematic literature review. And essentially what this tool is it allows us to really assign points to different risks or different aspects of a patient which increases the risk. So for example, based on gender, filler type, site, vessel, or time to presentation, we were able, based on our findings, to create a risk stratification tool, which allows us to stratify the risk into low, moderate, and high. And what this really allows us is to use this in advance to support personalized treatment planning. So essentially, if a patient comes in wanting to do a filler in a specific area, we could say that, based on the area that we're targeting and the vessel in that proximity of this area and the type of filler we're going to use, that it's either a low, moderate, or high risk procedure. And this just allows us to educate the patients and to tell them that this is, sort of the risk. This is sort of based on this tool, what risk you're in. Are you happy for us to proceed? And it just allows us to take more care in the higher risk patients. Now, general things that we found is the use of cannulas are much safer than needles. So cannulas in the aesthetics world are the blunt tipped micro cannulas. The idea is that because they are blunt, you cannot go into a vessel or pierce a vessel because it's blunt. Now, that's not always 100% true, but it definitely minimizes the risk of that happening. And doing slow retrograde injections are recommended. So you want slow, low pressure and low volume injections. So even if you accidentally did inject something into an artery, at least it's a small amount and you won't have the large devastating implications and complications of vascular occlusions. Now, the most important thing really is early recognition. So recognizing when a vascular occlusion happens, and that can be pain, it could be blanching, it could be poor capillary refill afterwards. And this really allows you to identify early and also treat early. And as you saw from our data, that once you treat earlier, the outcomes are much more favorable. And really what we're trying to do is to see if there is potential to integrate this risk stratification tool into aesthetics training, but also into the generalized protocols and patient consultations in the first instance. Now, of course, there was some limitations of this study. The main thing really is most of our data came from case reports, and that all can lead to potential bias and underreporting. There is not huge amounts of prospective studies really in this field, and a lot of our data just came from case reports. And again, there's no real standardized definition of what a vascular occlusion is, so there might be some underreporting from that perspective. Now, what it does highlight really is key anatomical knowledge is paramount, and technique and early treatment is also very, very important. So that is the end of my talk. I wonder whether there's any questions regarding that. Any questions, anybody?